Role of surgery in locally advanced differentiated thyroid carcinoma. I am Dr. Dushyant Mandlik, consultant head and neck surgical oncologist at Astha Oncology Associates, HCG Cancer Center, Ahmedabad. We will review in brief about pathophysiology of locally advanced differentiated thyroid carcinoma, role of surgery in them, various surgical techniques involved, and outcomes of same. As you all rightly know that grossly advanced extrathyroid extension upstages the T stage from T1 to T3B to T4B. It also increases the final stage, which also impacts on the prognosis. In this retrospective review by MSKCC, male gender, age more than 45, extrathyroidal extension and distant metastasis were 4 high impact worst prognostic factors. Also, we need to know that only gross extrathyroidal extension has a negative impact on outcome. As you can here see that no extrathyroidal extension has almost equal prognosis like microscopic extrathyroid extension, but you can see that macroscopic extrathyroidal extension in those patients the prognosis is poorer. If you go about the risk of structural disease recurrence in ATA, gross extrathyroidal extension and incomplete tumor resection portends to high risk. The incidence of locally advanced differentiated thyroid cancer is in the tune of around 13 to 15%. Most of them are papillary carcinomas, elderly more than 50 years, and the size of tumor is usually more than 4 centimeters. There is high mortality associated with widely invasive follicular thyroid carcinomas, with advanced age patients, and incomplete excision. There are certain aspects, if you can check preoperatively, they can point towards this locally advanced carcinomas like abnormal vocal cord functions and subglottic tracheal mass in a suspected or proven thyroid lesion, or asymmetry of piriform sinus due to submucosal involvement. In a suspicious or proven thyroid lesion where there is a voice change and dysphagia, dyspnea or hemoptysis. In biopsy-proved systemic metastasis. In recurrent thyroid cancers following prior treatment, or proven thyroid cancer with invasion of visceral structures and or extracapsular extension in metastatic lymph nodes in imaging. 98 to 100% of the patients has relatively hard or fixed swelling, which can be accessed by the mobility of the laryngotracheal framework. 5 to 33% has breathing difficulty, around 25% has swallowing difficulty, around 18 to 22% has hoarseness and coughing, and 11 to 25% has blood in sputum, which may suggest luminal invasion. Beware of the normal voice as it has sensitivity of less than 33%, where there can be an compensated vocal cord function even though there is an locally advanced differentiated thyroid carcinoma. From anterior to posterior, the structures involved are strap muscles, recurrent laryngeal nerve, trachea, esophagus and larynx in the tune of 53% to 12%. In this 2006 paper by Ito et al., they have observed that the posterior extension has much less recurrence-free survival than the anterior structures involvement. All the patient must be evaluated in general head and neck examination Also, laryngeal examination, preferably fiber optic vocal cord examination, if required tracheoscopy and esophagoscopy must be done. In 2021, this Korean Thyroid Imaging Reporting and Data System Guidelines, also known as K-TIRADS, have specifically found out certain aspects of the ultrasound reporting which can tell about the structural involvement. As you can see here, the capsular disruption in the image A is suggestive of minor extrathyroid extension into strap muscles anteriorly. But the replacement of strap muscles by thyroid cancers in image B is suggestive of gross extrathyroid extension. Here, an obtuse angle between the cancer and trachea is highly suggestive of tracheal involvement. But ultrasound has its own limitation, including observer dependency. CT and MRI scores better in certain studies, and it also provides sectional imaging and is less observer dependent, which is useful for surgical planning also. As you can see here, in certain studies and experiences, endoscopic bronchial ultrasound had diagnostic age over CT and MRI, but it comes with a cost and invasive nature of the procedure. Here, in the Mayo Clinic experience by McCaffrey, we can see that why radical surgery is important, as the tumors or the patients where there was a complete resection or save excision was done, they fared much better than the tumors where gross residual disease was left behind. Similar results were found with MSKCC data. So what should be our goal of surgery and treatment? It says that all gross tumor must be removed, the vital structures must be preserved, every effort must be made to preserve the functioning recurrent laryngeal nerve, the tumor must be evaluated and the extent of disease is mapped and appropriate surgical resection is performed. Laryngectomy is rarely necessary as a primary surgical process. A balance must be developed between best local control and satisfactory quality of life. Sometimes adjuvant therapy like radioiodine and external beam radiations are required. This study by Shah et al. Concludes that for the strap muscles in the patients who were more than 55-year-old, the involvement of strap muscles by macroscopic ETE have an increased likelihood of disease-specific death compared to patients with no macroscopic extrathyroidal extension. Recurrent laryngeal nerve is involved in around 20 to 47% of locally advanced DTCs. It also increases the death rate in these patients by 5 to 35%, and we must assess the contralateral recurrent laryngeal nerve to have an appropriate management strategy. AHNS consensus statement guides regarding management of recurrent laryngeal nerve involvement. It emphasizes not to sacrifice a functioning nerve and to avoid bilateral vocal cord palsy. In case of the sacrifice, the nerve should be repaired with microneural anastomosis, either end-to-end or with a graft by ANSA or greater auricular nerve or other techniques. E.G. et al. Has reported that immediate recurrent laryngeal nerve reconstruction at the time of thyroid cancer extirpation can provide excellent postoperative phonatory function. Neuromonitoring works as an important agent by helping in guiding the extent and timing of contralateral surgery, and this information can also help us to make a decision to preserve or sacrifice the nerve. It also helps us to have an idea to go for elective tracheostomy or not. 6 to 21% of locally advanced differentiated thyroid cancer present with laryngotracheal complex invasion. Out of them, 0.5 to 1.5% has intraluminal component, 13.5% have involvement of tracheal surface only. McCaffrey et al. Suggested 4 mechanisms of laryngotracheal involvement. The first is by disease extension from the superior pole around the posterior border of thyroid ala to involve the paraglottic space. The second route involved invasion of the trachea by a metastatic lymph node. The third route of spread, the author described direct invasion of the thyroid ala by the disease in the superior pole, and finally in the fourth route, the spread was through direct invasion of the cricoid or trachea from the primary tumor in the isthmus. Sheen et al. Proposed the classification of the invasion of trachea by the thyroid tumor by the virtue of involvement of the various layers of the trachea. As you can see in the stage 4, the tumor is invading through and through the trachea and going endoluminal, and that is the stage has the worst prognosis. Keshuke et al. Recommended various strategies depending on the Sheen and McCaffrey classification. The same procedure should be performed by scalpel when there is superficial tumor invasion. In case of deep invasion to submucosa, tracheal area invasion will necessitate resection and reconstruction surgery, such as window resection with tracheal cutaneous fistula and circumferential resection with end-to-end anastomosis. Cricoid and tracheal deep invasion required more complex surgical methods such as window, bayonet line or sleeve line resection, and tetris surgery. Extensive laryngeal invasion to the vocal cords and paraglottic space required partial or total laryngectomy depending on the area and extent of the invasion. In this series you can see the Sheen for invasive tumor in the trachea. There is an pre-op endoscopic examination suggestive of intraluminal tumor. There is an resection of 4 tracheal rings and anastomosis is done. You can see the tumor in the lumen in the final specimen, and endoscopic examination with good healing at 18 months post-surgery with well-controlled thyroglobulin. Esophageal or hypopharyngeal invasion occurs in around 20% of this type of tumors. Resection and closure is advised when the mucosa is free, and segmental resection and reconstruction is required when intranumeral extension is there. In great vessels, the surgery is the best treatment. Veins are involved more than arteries, and intraluminal thrombus can cause cerebral infarcts or bleeding. IJV reconstruction should be done especially when there is bilateral venous thrombosis. In this interesting study by Vaughan et al., the treatment outcomes were seen according to the risk factors, and in univariate analysis, male patients where more than 2 cm of the tumor with more than 5 nodes were involved fared worst. But interestingly, on the multivariate analysis, only the post-ablation stimulated thyroglobulin was more than 1 nanogram per ml. They had significantly fared worst. This makes us think about biology more than anatomy in this subgroup of thyroid tumors. Thank you.